Hello everybody and welcome to the Thursday edition of Video Clips. I want to talk about anorexia today, and we can substitute anorexia for any other eating disorder as we talk about the issues surrounding it, but the causes of anorexia and the nature of the condition are not well understood, so it's not surprising that treatment programs for it are miserably ineffective. In fact, most women, and patients are mostly women, don't fully recover from anorexia, and about 15% of them die of either suicide or health complications resulting from their eating disorder. However, there is a program that has been proven to be effective called the Maudsley approach. The program was created by therapists at the Maudsley Hospital in London as an alternative to inpatient care in a hospital. Now, there are several things that make the program different. The treatment is family-based, while most treatment programs here in the United States separate the patient from her family and are based on the concept that the family is probably part of the problem. And while most traditional treatment programs focus on weight gain, the Maudsley developers insist that weight gain alone is not enough for recovery. The outcomes are very different for Maudsley as compared to traditional therapy. Studies have shown that 2/3 of adolescent anorexic patients are fully recovered at the conclusion of family-based treatment, and 75 to 90% are fully weight recovered at 5 years of follow-up. The most successful U.S. programs, just to give you a comparison, have an efficacy rate of about 33% based on short-term follow-up, and much worse based on long-term follow-up. Furthermore, the program is conducted on an outpatient basis and averages only 20 sessions during a 6 to 12 month period, significantly less expensive than traditional inpatient programs, which can be ridiculously expensive, sometimes $1,000 a day or even more. 80% of the patients who go to the Maudsley program with their families are weight restored and have started or resumed their menstrual periods by the conclusion of treatment. Success is largely attributed to family participation, and again, the approach is opposite here in the United States. Parents are expected to play an active role in the therapy of their children and to participate in discussions about their child. Traditional interventions treat parents as unnecessary and go so far as to say that the child-parent relationship is the cause of the eating disorder and that contact or involvement with parents can interfere in the recovery of the patient. During the first phase of Maudsley, on the other hand, the therapist teaches parents how to refeed their child and work with the patient to reframe her relationship with her siblings. The therapist participates in family meals during which he or she can observe the family's eating patterns. Parents are instructed not to be critical or ambivalent, but rather to be persistent in letting their daughter know that starvation is not an option. The therapist also engages the patient and her family in discussions about the consequences of anorexia-induced malnutrition. When the patient begins to accept the parent's demand to eat more, the family's outlook changes, usually a great deal of relief because things are getting better, and weight gain has begun. It's time then to move on to phase 2 of the treatment. At this time, parents are taught to help their daughters take more control over eating. While some discussion does take place about family relationship issues, this discussion is only included to the extent that it focuses on identifying and discussing issues that impact eating and weight gain. While traditional therapy focuses on identifying and discussing the causes, Maudsley practitioners say that the cause is somewhat irrelevant because once a patient develops anorexia, the disease takes on a life of its own. Symptoms are predictable and include depression, withdrawal, anxiety, rage, irritability, and suicidal ideation. Thoughts about eating and food are distorted in part due to a lack of adequate glucose to the brain for a long period of time. The focus should be on refeeding and weight gain in order to facilitate a return to rational thinking. And by the way, Maudsley seems to be based on the cognitive theory of helping people overcome psychological issues, which is that there's just only so much time and energy you want to invest in looking at the cause of a problem. At some point in your time, you just say, look, whatever caused this in the first place doesn't really matter. This is the problem we have right now, and we're going to focus on fixing it right now. We can go back and figure out how this all happened and all that later on, but we have to focus on the issue today. And in the case of an anorexic who might have been starving for a long time, the situation is so life-threatening, there's no choice but to focus on changing the behavior right at the moment. Now, once the patient reaches and can maintain weight above 95% of ideal weight on her own, treatment shifts to helping the patient understand the impact anorexia has had in establishing a healthy adolescent identity. This includes issues such as personal autonomy and healthy parental boundaries. Now, Harriet Brown's daughter, Kitty, developed anorexia and was diagnosed at age 14, weighing 71 pounds. Brown reported the story of her daughter's recovery in a New York Times article a few years ago, which I found very interesting when I was researching to write this article. Both she and her husband were appalled at the condescending way traditional therapists talk to their daughter, the outrageous costs, as much as $1,000 a day for inpatient treatment centers, and the high failure rate of these very expensive programs. Brown started looking for options, and she discovered the Maudsley program. She reported a conversation with Daniel LaGrange, who trained at Maudsley and is assisted in writing treatment manuals for therapists and books for parents. She asked what LaGrange thought about parental involvement in therapy, since it's considered such a taboo thing in the American approach to treating eating disorders. He replied, "If your child has diabetes and doesn't check her blood sugar often enough, you'd make sure she did." And he went on to talk about the fact that excluding parents from something as important as a life-threatening disease, which anorexia does become at some point in time, is a ludicrous way to approach health. Any health issue, anything going on in the family for that matter. And I guess my side comment here is, just like everything else, treatment for anorexia defies logic, just like treatment for coronary artery disease and diabetes and all the other things I've talked about for so many years on these video clips. It just all doesn't make any sense at all when you understand the etiology of the disease. So anyway, I digress, but back to the story here. Brown reported in detail the process of refeeding her daughter, which involved gradually increasing her calorie intake until she was consuming as much as 4,000 calories a day. Either she or her husband had to sit with Kitty during 3 meals and 2 snacks per day to make sure that she was eating. One of them took the child to work every day, and during this time, the whole goal of the family was to refeed Kitty. Constant diligence was required in order to make sure that Kitty did not throw away food and that she ate all of the food that was given to her. She was forbidden to exercise with the exception of family walks around the neighborhood. In response, Kitty's behavior understandably was sometimes awful. She alternated between rage, anger, hostility, and resignation. Brown described long sessions during which Kitty cried, refused to eat, called herself fat, and she said it was very tempting sometimes to give in, but the parent in charge would sit there and wait until she finished her food. Brown's experience is typical. According to research, reason and insight are of little use in getting anorexics to eat. Persistence and refusing to take no for an answer are the only options for recovery. Refeeding can even be more stressful due to the high calorie intake needed for weight gain. Anorexic patients become metabolically inefficient as a result of their starvation. They convert more energy to heat than healthy people, which means that an anorexic patient may require significantly more calories just to gain a single pound than other people might require. Exercise can exacerbate the problem, and that's one of the reasons why in the case of Kitty and her family, the family was instructed to not allow her to exercise. And I know in the anorexic patients that we've had here at Wellness Forum Health, many of them were as excessive and compulsive about their exercise as they were excessive and compulsive about their starvation. So breaking that cycle becomes very important in the restoration of the individual too. In addition to the forced feeding at home, Kitty did see a therapist regularly and was monitored by a pediatrician. A new study lends some additional insight into anorexic behavior that reinforces why traditional treatment fails and the Maudsley system is so much more effective. Extreme dieting and starvation, which are characteristic of anorexia, becomes an entrenched habit which can then become very difficult to change. The authors of this new study that I'm going to talk about say that anorexia is essentially like any compulsive behavior, which is characterized by making self-destructive choices in the short term, even though the long-term consequences of doing so can be terrible and even life-threatening. In this study, brain activity was monitored in 21 anorexic women and 21 healthy women while they decided what to eat. Not surprisingly, anorexic women were more likely to choose low-fat, low-calorie foods. They also didn't rate high-fat, high-calorie foods as desirable. In all of the women, the part of the brain associated with rewards showed some activation. But interestingly enough, in the anorexic women, there was more activity in the dorsal striatum, an area involved in habitual behavior, indicating that these women were not actually thinking about their food choices, but rather just practicing a bad habit. Senior author Timothy Walsh stated that the basis for the study was a paper he had written in 2013 suggesting that the path to anorexic behavior starts with weight loss, which is rewarded with compliments and then accompanied by relief from anxiety. Over time, not just the weight loss, but the starvation itself starts to become rewarding, and thus the habit of starvation is formed. In his paper, he hypothesized that the development of the starvation habit could be reflected in the dorsal striatum, which was confirmed in the study. Welsh says that the longer the habit is practiced, the harder it is to break, and that this explains why antidepressants and traditional talk therapy don't work, since habits have to be replaced by other behaviors. Welsh's ideas and findings are consistent with the stance taken by Dr. Lance Dodds and his son Zachary Dodds in their book, The Sober Truth. I did a couple of advanced study classes on this book, and I found it quite fascinating. The book addresses addiction and the failure of 12-step and rehab programs to actually work and treat addiction effectively. Addiction is really compulsion, the Doddses say. And compulsions are methods of relieving emotional pain. Resolving compulsions requires identifying the cause of pain and then addressing it. But in order to find and address the cause of pain, people have to be able to think and communicate. The importance of continuing to insist that Kitty, in this case, eat enough food to regain and maintain her weight was crucial in restoring her brain function, which then could allow her to benefit from therapy. The happy ending to Kitty's story was that she reached her goal weight, she started growing again, and she returned to normal. As is so common in almost everything in the medical field, her recovery was because her parents took charge of the situation. They did their own research. They refused to enroll her in programs that made no sense and had been proven to be useless. The treatment that worked for her could never be conducted in an inpatient setting for many reasons, ranging from the length of time to recovery to the amount of time that would be required daily to prepare food and to force Kitty to eat it. Additionally, while this was not part of the story and not part of any research study that I've looked at so far, I have to believe that the commitment that these parents made to their child's recovery had to have had an impact on Kitty's desire to recover. Attention from nurses and dietitians can never be a substitute for parental love and commitment. One concern expressed by critics of the approach that I've described here, the Maudsley approach to anorexia, is parents may find it difficult to make a similar commitment. But I'm sure that knowledge of the failure rate for other options would be a powerful motivator for many. And there are few challenges associated with child rearing that don't require considerable time, energy, and resources. And I think this is very important. There are a number of people who suffer from a variety of eating disorders, ranging from anorexia and bulimia to compulsive eating. I think that the strategies that are used to help these people are miserably ineffective in the short term and in the long term. And it really isn't until we start looking at the underlying cause and helping people there that we're going to see these situations start to resolve. So anyway, the treatment is Maudsley. There are several references that I've used in this article. Will be posted in the Health Briefs library shortly. So I hope that this is helpful for you or a family member or somebody who you know suffering from this awful, awful, awful and life-threatening disorder. All right, that's all for today. As usual, pass this on to anybody who you think might enjoy watching it, and I will be back to you next week with more news.